the audience, I wanted to let you know that we will be coming out with another PEDS newsletter soon, probably this month, and we'll have some updates about COVID and also a new newborn nursery staffing model that we're working on with our pediatric hospitalists. So I want to introduce Dr. Marcia Russell. Dr. Russell did her residencies in Jamaica, and as well as did a Med Peds residency at Yale. She became certified in pediatric infectious diseases in 2011, and she comes to us at Rex from Betsy Johnson in the Harnett system. She loves to teach and has been an associate professor and supervised residents and medical students and PA students as well. And we're very happy to have her as one of our hospitalists who's been taking care of babies up on the 7th floor and also helping us out in the newborn nursery. Today, she's going to talk to us about febrile conundrums, and please welcome Dr. Russell.
Thank you, Mary. Good morning, everyone. So as the topic suggests, febrile conundrums in children, what I decided to do today was just to go through a series of cases because, as you know, fever is one of the most common presenting complaints in the pediatric office. And certainly, a number of times it can be a dilemma as far as conditions, especially when fevers are prolonged. And so in going through this presentation, what I'll be doing is sharing some case-based presentations that I've seen over the last 3 to 4 months, instead of just talking about fevers in general, and just to give some general guidelines and principles in how to manage these infections. So the first one, case that I'll be starting off with is a 22-month-old Caucasian male who presented to the ID clinic with fevers for 5 weeks. In terms of the history, there were no ill contacts. There was normal growth and development. And per his parents, the maximum temperature at the time was 101 at home, which they described it being usually at midday, but by nights it was gone. By the time he had presented, he had been evaluated by his PCP. The only thing significant on labs at the time was that he had a rapid strep that was positive, and he was treated with amoxicillin for 10 days. However, fevers persisted. In terms of review systems, the only thing that was significant is that on one day of this illness, he had vomited twice and had had a rash, but which had resolved within a day. The past medical history was significant for recurrent otitis media back in 2018, and he had tubes that were placed in 2019. As far as the family history, he has a cousin with IgG deficiency, and multiple family members had thyroid disease. His immunizations were up to date, and as far as his meds, he had just been on Tylenol. He lived in Clayton. They described being in a rural area, which was wooded. There were no ticks, no cats, no animal exposure, and there was no history of any travel. So by the time he presented to the clinic, he had had, as I said, some evaluations that were already done by the PCP. And the only thing here that was really significant was a platelet count of 507 with some mild thrombocytosis. All his viral testing so far as EBV and CME were negative. Blood urine cultures were no growth. A urinalysis was negative, and his thyroid functions were normal. So when he presented to the clinic, he was afebrile that day. And in terms of exam, this was a normal 22-month-old child. He was well appearing, vitals were all normal, and really nothing significant in exam. I had the labs repeated that day, which really didn't show anything significant. The thrombocytosis had resolved. His electrolytes were normal. His inflammatory markers, the ESR and the CRP, were all normal. His chemistry was normal. uric acid were normal, AME, rheumatoid factor, and Bartonella titers were all normal. And his immunoglobulins, as well as his vaccine titers, were all normal. With that, we just continue to observe him. And on follow-up with his pediatrician, or I should say LFTs were also normal. To follow up with his pediatrician within a week, and at that time when seen in the office, she described he had an erythematous mild facial rash with some shorty cervical lymphadenopathy. The temperature in the office at that time was 100.3. By this time, it was going up to about 6 weeks of fever, and so we decided to further investigate him. And he had an echo that was done, that was normal. Abdominal ultrasound, that was normal. PPD, respiratory viral panel was normal. And because of the rash on his face with the parvovirus titers, and that was also normal. 2 months later, on follow-up, he was still having fevers. Parents report really no change in symptoms. He was well parent still, and at that time, labs again repeated showed normal inflammatory markers with a normal CBC, with a HIV test and quantiferin test being done at that time, which were all normal. So basically, still with fevers, with normal labs. Going into 10 weeks, he had a rheumatology evaluation. At that time, parents reported that the fevers were mostly in the afternoon with no temperatures of 101. Still having shorty cervical lymphadenopathy on exam, otherwise normal. In the rheumatology, sent ferritin and an autoinflammatory panel. The ferritin was a bit low, and I think that panel is still pending. So what is the cause for these prolonged fevers? At this time, it's almost 3 months, and the cause is still unknown. He still remains with fevers. So you'll hear these terms floating around: prolonged unexplained fever, FUO, fever of unknown origin, recurrent fever, recurrent explained fever. And what are all of these really? For fever of unknown origin, there is really a lack of a standard definition. The original literature included a time course of up to 3 weeks. Right now, we're saying it's a temperature greater than 100.4, greater than 8 days, without a clear source. And the categorical distribution of diagnoses have shifted compared to previously reported studies. So previously, infectious causes were really described as the most common cause of a FUO, but in the latter years, the distribution is actually shifting where it is now unknown. What we do know is that it is a dialectic dilemma. It causes anxiety to the parents, and it's a source of confusion and frustration for the physician. It may lead to unnecessary testing and medicines, and it's a costly evaluation. And most of the times, usually, it may be an uncommon presentation of a common disease when we do find an etiology. In terms of evaluation, you want to ensure that a fever was documented, and this is usually, something you have to explore really well on the history. And to ensure that this is not pseudo FUO, which is really successive episodes of benign self-limited infections that the parents perceive as one prolonged fever episode. You may have at times too with the pseudo FUO that you have a lot of anxiety, whether in the child or the family, and parents may be perceiving these children as having fevers. One of the things you want to elicit as well is the pattern of this fever. Is it intermittent, recurrent, relapsing, sustained? And sometimes this can help to clue you into the diagnosis and, to get a sense of the periodicity of the fevers. In terms of the history, the cardiac elements, you definitely want to know any symptoms, the travel history, whether in the country or out of the country. You want to know about pet exposures, and not just at home, but, elsewhere, whether they went to a grandparent's house, a friend's house, what animals they might have been exposed to. Food exposures, of course, will help to clue you in on, some of the infectious causes. And immunization, you want to make sure that that's up to date. You want to go through knowing your medications, your allergies, past medical history, and of course with ethnicity, especially important in some of the periodic fevers. Geographic location is also one thing that may clue you in to a cause. On exam, you want to make sure you look at the growth parameters, including trends. For the head and neck exam, it's important to look for ulcers, lymphadenopathy, to assess the conjunctiva, and to see what the ears and the thyroid exam is. The rest of the exam is really looking for obvious sources. As far as the cardiovascular and respiratory systems, murmurs clue you into things like infective endocarditis, tachycardia, while tachypnea and dullness may suggest a pneumonia. As far as the skin, you want to be looking for rashes, joint tenderness. As far as autoimmune condition, rashes or bites, especially with cat scratch disease, and just looking at the nails if there are any abnormalities. The GU exam looking for urethral discharge or ulcers. Of note, a normal physical exam at the initial FUA evaluation is highly indicative of a benign cause. And so what are the causes? Infectious, as I said previously, without that used to be the most common cause. However, and I'll show you later on that we're gradually moving away from infections as the most common cause. Certainly we have to think about autoimmune causes, oncologic, neurologic, genetic, factitious, iatrogenic, and undiagnosed. The infectious causes are many. EBV and CME are certainly at the top of the list that are common, and these are two of the viruses you definitely want to start checking for at the onset. Bartonella, Yersinia, tuberculosis, and non-tuberculosis mycobacteria. And as you can see here, there's a whole list of infections, which I'm not going to necessarily go through today, but as the list is so long. But the point is that we don't have to go looking for all of these infections, and basically just using a targeted history on exam and then evaluating for these infections based on what we get. Of course, the non-infectious causes, Kawasaki, GIA, SLE, hemophagocytic syndrome, vasculitis, sarcoidosis, inflammatory bowel disease, malignancy, are causes you want to evaluate for. And you have to think about drugs and the factitious, and whether there are any CNS abnormalities, as those can give you central fevers as a cause of FUO. So if you remember, I mentioned before, when you take eliciting the history, you want to figure out, are these fevers persistent? Are these fevers recurrent? And an approach to, if you're talking about recurrent fevers, is to get a history as to, are the infections identified, or are these stereotypical episodes that are, where infections are not identified? So when infections are identified, then you need to consider, if you have multiple minor viral infections with URI symptoms, you need to assess the environment, childcare and smoking. And one of the things we always have to enforce to families is that, well-appearing kids may have up to 10 infections per year, and even more when they're in the daycare. Now, if there are multiple bacterial illnesses or severe viral illnesses, if the infections are involving different organ systems, this is one of the times you want to go ahead and assess for immune deficiency. If the infections involve the same organ system, then you want to assess predisposition of the target organ system. So example, obstructive uropathy giving you recurrent UTIs, pulmonary anomalies giving you pneumonias, allergies, eczema. Then as far as, the stereotypical episodes when infections are not identified, then you want to get the history. Are these occurring at regular episodes? Especially, are there oropharyngeal symptoms involved? Because the two biggest conditions where you'd have this as a presenting complaint is that of cyclic neutropenia and FAPL, which is periodic fever, aphthous ulceration, adenopathy, and pharyngitis. If the fever pattern is a little bit more irregular and you have specific suggestive symptoms, some of these are like abdominal pain, chest pain, rashes, then you want to think about some of our monogenic hereditary fever syndromes. So, as I mentioned before, as far as lab evaluation, we can just go about this by a tiered approach. But I would say in general, most kids should have these labs done at the onset, a CBC and a differential, blood and urine cultures with urinalysis, inflammatory markers, as well as a complete metabolic panel, respiratory viral panel, EBV and CMV titers, Bartonella, even if there's no history of a cat bite, and chest x-ray. The other investigations, I would say, should be targeted depending on if there are any findings on your history and exam. In terms of management, one of the first things you always want to do is discontinue all non-essential medications, including your antipyretics. Remember that drug fever is a common cause of FUO. Important thing is, if you have a well-appearing child, you always want to hold your empiric antibiotics. And if you're not sure what's going on as well, I would say hold steroids, because having given antibiotics and steroids without a clear cause may mask conditions. Most of this workup can be done as an outpatient. However, indication for hospital admission would be if symptoms are progressing with clinical deterioration, or if there is any concern for maltreatment. So, as I mentioned before, the trend is now shifting to say that that infections are not the most common cause, and a lot of cases are undiagnosed. And I wanted to take one look at this study, actually. This is a study that was done where patients were referred to a pediatric infectious disease clinic for unexplained fever. Some of these fevers were prolonged, and some of these fevers were recurrent. So with 221 patients that were seen in this study, 152 of these patients had recurrent fevers and 69 had prolonged. And in this category at the time, when patients showed up, based on diaries and journals and further history, 10 of them were found as not to be having fever. Of those with having fever, 11 diagnoses were made on the initial visit, which were, usually like some simple infections. But the majority of them turned out to be fevers, fever of unknown origin. And as you can see in this group of the FUO, the majority of cases that diagnosis was not established. As far as the recurrent fevers, this group was further divided into intermittent fevers and periodic fevers. With 60 patients having a history of periodic fevers, of this amount, 39 were found not to have a diagnosis. 21 were diagnosed with a periodic fever syndrome, and of these, 20 were diagnosed with FAPA. The other group was categorized as intermittent, and in these, once again, the majority of patients, they were either self-limited illnesses or no diagnosis established. Only 8 of these patients had a diagnosis established. But in general, when looking at the overall trend, 95% of these patients were not having a fever. They were having self-limited illnesses or found to have no cause for their fevers. Of these patients, only 2 had a serious infection, which is malaria and typhoid, and 10 had non-serious infections. And I'll show you this on the next slide. And whenever patients were found to have a serious illness, it wasn't a mystery. There was usually suggestion from the history and exam. So in this case here, where you had GIA and SLE, there was always something on history here where you had like fatigue, joint pain, rash, family history, joint swelling that would clue you into the diagnosis. And as far as the kids who had IBD, they had some GI symptoms, whether it be abdominal pain, decreased appetite, constipation, bloody stools. The two infections that were described, these two patients had a history of travel and, definitely other symptoms as well. And the rest that were diagnosed did have symptoms, that were suggestive. The child with familial Mediterranean fever was from China. The patient with hemophagocytic lymphocytosis had some lymphadenopathy, headache, fatigue, and muscle pain. And the child with ALL did have, constitutional symptoms with lymphadenopathy. And the child that had rheumatic fever had a heart murmur, joint pain, and muscle pain. As I mentioned before, the evaluation can be costly. And just looking back at one study back in 2018, where they looked at a number of children that were admitted to hospital between 2002 to 2012. In this study, however, they didn't find that the cause had changed that much. However, what they did show was that the average length of stay for these kids were 8.6 days, and the mean hospital cost was $48,000 approximately. And here again is where all of these patients had imaging, but rarely led to the final diagnosis. Those actually that had positive imaging had suggestive findings on their history and physical exam. So is it a concern that we're not sure as to these undiagnosed cases? And not many studies have really looked at what's the long-term outcome, but however, there have been a few described. And just looking back at this study, a retrospective review of patients back in DC, here, this was done recently, and as you can see, the undiagnosed cases were just about almost the same as the infectious causes. And as far as long-term health outcomes, this is a study 8 years later from the original study that I showed you with the 221 children. At the end of 8 years, only 3 of these patients were really found to have a fever-related diagnosis. These 2 patients here, they actually had rheumatological conditions, which were diagnosed later in the illness after a year at least. And this one patient was a patient with cerebral palsy that was thought to be centrally mediated fevers. So as you can see here, based on this pattern here, the majority of these, were periodic fevers. 21 were prolonged, 65 were intermittent. But at the end of it all, when followed up in 8 years, all of these patients were well and never had any fever-related diagnosis and did not have any complications apart from the 2 that I mentioned earlier. And in terms of length of fever, not much done out there as well, but in this one study, it was shown that the length of fever can be anywhere between 16 days to 6 months, with a mean of 58 days and a mean of 5 years. And they followed up these patients for a median time of 3.5 years. And in this study as well, 16 and 19 of these patients were well and had no recurrence of fevers or chronic medical conditions. 2 of them developed febrile seizures, and 2 were diagnosed with rheumatoid arthritis. So the lessons to learn: the majority of unexplained fevers are benign. Serial histories and physical exam is crucial, and serial evaluation and measured lab workup is going to be needed. There's an increasing trend now towards unknown cases, And early antibiotics or steroids can obscure or delay making a specific diagnosis in children with FUO. Children with serious illness rarely present with fevers alone, and many children with unexplained fever without red flags are likely to improve without having a diagnosis made. And so one of the questions we need to ask ourselves is, do we really need to embark on a fishing expedition in well-appearing children? And just to mention a bit about the periodic fever syndromes, I'll not be talking about all of these, but FAPO is one of the most commonest causes that we should all be well aware of. Cyclic neutropenia will present similarly to FAPO, meaning it can present with the ulcerations and the lymphadenopathy, with the fevers occurring at regular cycles. However, the big thing with cyclic neutropenia is that this is not an inflammatory condition. This is a hematological condition. And so this is associated with neutropenia, and so you'll have more serious bacterial infections. The hereditary ones, familial Mediterranean fever is the most common one. Mevalonochinine deficiency is formerly known as the hyper-IgD syndrome, and you have the tumor necrosis receptor associated periodic fever syndrome and the cryopyrin associated periodic syndromes. With these, the fevers tend not to occur at recurrent cycles, and they'll tend to present more with other symptoms, as I mentioned before, like with familial Mediterranean fever, they'll have serositis, and so may present with abdominal pain, chest pain, and they may present with a rash. But FAPO, which is one of the most common things out there, the flares usually last about 3 to 7 days, and the fevers will occur at intervals of 3 to 8 weeks. It is really benign. Spontaneous resolution will mostly occur before puberty, and 20% who have initial recovery will be followed by flares in adulthood. It has an excellent prognosis, however. With comparison to the familial fevers, you want to make sure that you make a diagnosis, because the risk of those conditions is that you can have developed progression to amyloidosis. So with FAPO, the diagnostic criteria, you have regularly recurring fevers with early age of onset, which is usually less than 5 years, occurring in the absence of upper respiratory tract infections. And usually one of the following is present: stomatitis, lymphadenitis, and pharyngitis. You need to exclude a cyclic neutropenia, and there should be an asymptomatic interval between the episodes. There is normal growth and development as well. The treatment, steroids are 95% effective, usually prednisone at a dose of 1 to 2 milligrams per kilo. However, other steroids can be used, betamethasone, dexamethasone, showing efficacy in 84% in one case series. The use of steroids is actually one of the things that helps to diagnose with FAPO, because the fevers usually abate in a few hours, and if not, then you really need to reconsider diagnosis. As far as prophylaxis, colchicine is one of the medicines that have, they're shown to decrease the febrile attacks when compared to controls. And there are some reports about cimetidine. However, the usefulness, the evidence for usefulness is really weak. Surgery for those patients who are not responding to the steroids, tonsillectomy without adenoidectomy, and this has been shown to stop disease flares with reduced frequency. The benefit-risk ratio should be discussed because, as you know, FAPO is pretty much a benign condition, which will eventually resolve. Other therapies, IL-1 inhibition, and so anakinra has been discussed as a possible use. And once again, this is where you would want to, discuss the benefit risk, because this is expensive here. Vitamin D, there's been a correlation between FAPO and vitamin D deficiency, and some studies have shown that supplementation with 400 international units showed a reduction in the number of febrile episodes and shortening of the mean duration of febrile episodes. So going on to another conundrum is when you have fevers and a rash. And this is, of course, one of the most common causes of kids who present to the emergency room, the primary care clinic, and certainly in the hospital as well. Viral illnesses are most common, but the history and key is most important in identifying emergent conditions. And as far as viral illnesses, those usually present with a maculopapular rash. In the day of now with immunizations, rubella and measles are really not seen, but we still need to know what the presentations are with measles, conjunctivitis, cough, runny nose, fever with complex spots, and rubella, headache, low-grade fever, sore throat, with coryza, with lymphadenopathy. Both usually have the rash spreading from head to the face and spreading cephalocaudally. And roseola is one of the more common ones where you usually have 4 to 5 days of fever and then a rash. The big ones you don't want to miss are, whenever you do have your petechial rashes, and meningococcemia is one of the ones you don't want to miss, as well as Rocky Mountain spotted fever, as well as your toxic shock syndrome, which is usually caused by group A strep and staph. With your toxic shock syndrome, you're going to have redness with every erythroderma that blanches on pressure. Staph scalded syndrome is one too, but that has typically, the bullous or the ruptured bullae that you may see on exam. Some of the times you can have a papular rash, which pretty much may be a source of confusion for scarlet fever. With prolonged fevers and a rash, you always want to entertain as well Kawasaki disease. And as you know, this is the classic history is that a fever for 5 days and 4 out of 5 of the clinical features. And the big things are conjunctivitis, which is a non-exudative conjunctivitis, and it's usually bilateral. Red lips, red pharynx, strawberry tongue is what has been described. Extremity changes where you can have painful swelling or redness of the extremities. And the rash is usually, can be of any type. It can be described as morbilliform, maculopapular, scarletiniform, or like an EM type of rash. And the other features that usually you should have unilateral anterior cervical lymphadenopathy with at least one node being greater than 1.5 centimeter in diameter. You always have to think about incomplete Kawasaki as well. And here is where you have the fever for 5 days, but not quite, but all the features to support this. And so in this, you want to do additional labs to help to assess whether or not this may be the case. The labs usually start out with are your inflammatory markers, and if those are elevated, you want to go ahead and do CBC, your Chem7, and your urinalysis. And if you have 3 or more of the lab findings of anemia, thrombocytosis, hypoalbuminemia, or elevated LFT with an elevated white cell count, or a positive echocardiogram, that would suggest a diagnosis of incomplete Kawasaki. If the inflammatory markers are normal, you want to see your clinical and lab evaluation and if fevers persist, and you definitely want to do an echocardiogram if typical peeling develops. One thing I should say is that especially in children who are less than 6 months with prolonged fevers without a cause, you want to have a high suspicion and to rule out Kawasaki as well. So moving on to the second case, one of the other things that, with fevers and prolonged fevers and a rash, as I mentioned before, in terms of the emergent ones, you want to think about Kawasaki, but more recently, you want to also think in this day and age with COVID, is the multi-inflammatory syndrome that's associated with COVID that may have features suggestive of Kawasaki. So this case is that of a 10-year-old boy who had a history of being positive for COVID 19 days prior to presentation. At that time, he had been perfectly well. The only reason why he was tested was because his mother had been sick. When he presented on day 19, he had a fever of 101. He had a rash on his lower abdomen, lethargy, abdominal pain, vomiting, and diarrhea. He had no conjunctivitis, swelling, or lymphadenopathy, and he had no peeling of the hands and feet. When he was seen in the ER, he was non-toxic appearing. He was febrile up to 38.3. Heart rate was 120 to 130, and he was found to have a maculopapular rash on his abdomen and leg. He received 2 fluid boluses, but had persistent tachycardia, and so was admitted to hospital for further evaluation. In terms of his labs on presentation, a mild elevation of his white cell count with elevated ANC, as well as a leukopenia as well. His CRP was elevated slightly, and his chemistry tests were normal. His AST was slightly elevated. Knowing the big thing here was knowing the history of that he had COVID that was diagnosed. The working diagnosis here was, watching this boy to see if he was developing symptoms of these multi-inflammatory symptoms. His EKG showed sinus tachycardia, his D-dimer, ferritin were elevated, and his PT was a little bit abnormal. At the time of presentation, his COVID PCR was negative, and his chest X-ray was negative. So he was admitted to the hospital, to the PICU, and he was a well-appearing boy despite being febrile and tachycardic. He was well-appearing and just had this rash. He was starting on Lovenox prophylaxis, and within the first hospital day, the rash progressed on the leg. Then he was noted to have strawberry tongue with red lips, as well as persistent fevers. By the second hospital day, his inflammatory markers worsened with persistent fever. His echo at that time had been normal, but his CRP had increased, tripled, his D-dimer had doubled, and the fibrinogen had increased. At that time, he was given IVIG and Solimedrol because of concerns of progression, concerns that this was MISC, and so he was started on IVIG and Solimedrol, and on that day, his COVID PCR was also positive. As far as his hospital course, despite getting IVIG and Solimedrol, the fevers were persistent, his inflammatory markers were worsened, and so because of that, he was given a repeat course of IVIG. The repeat echo was normal. By hospital day 6, he was afebrile and steroid weaned. However, the day after that, his rash worsened. He had conjunctivitis, fevers, tachycardic, and had new oxygen requirement. The echo at this time did show abnormalities with coronary dilatation. His inflammatory markers were worse. The D-dimer had increased, and the BMP had peaked to 4,240. The chest X-ray showed atelectasis, and so pulse steroids were started for high dose for 3 days. Because of the new oxygen requirement, the concern was that of pulmonary embolism too as well, and Doppler ultrasounds of the legs also had been done, which were negative. So by hospital day 10, his labs improved and his echo was normal. The rash improved, inflammatory markers improved, and he was transitioned to oral steroids. And he was discharged. He was put on prophylactic Lovenox and discharged home on a steroid taper. 2 weeks post-discharge, he was noted to have periungual desquamation of the nails. Diagnosis, MISC. And a similar case, well, not same presentation, but this is a 6-year-old girl who was initially being treated for a UTI, who when presented to UNC had fevers for 5 days, headache, sore throat, neck pain, and swelling, but had a petechial rash with abdominal pain and emesis. She had a history of COVID exposure. At the outside hospital, she was tachycardic, hypoxemic, and in shock. the COVID was negative at the outside hospital. When she presented as well, she was noted to have the neutrophilia and the lymphopenia with elevated inflammatory markers. Her LFTs were only significant for hypokalemia at the time, with abnormal LFTs, and her troponins and BNP were elevated. And as you can see there, the rest of her coax studies were also abnormal. The COVID PCR and the COVID IgG were positive. As far as her hospital course, her hypertension was unresponsive to fluid. She required pressors and had to be put on hydrocortisone. Eventually had hypoxic respiratory failure, started on high flow, but eventually had to be intubated because of ARDS. And her echo had showed severe diminished left ventricular function. She had to be transitioned to ECMO on hospital day 2 for cardiogenic shock. So she was started on vancomycin, ceftriaxone, and clindamycin because of the shock. The clindamycin, of course, because of a possible toxin-mediated illness. She was also given remdesivir and CCP, which is COVID convalescent plasma. They're thinking that with her respiratory failure, this might be an acute COVID infection. But with these criteria, she definitely presented in what was no cardiogenic shock. And so this was suggestive of MISC. And so she was started on methylprednisolone, IVIG, and eventually anakinra, and was put on Lovenox. So she did well, however. She was weaned from ECMO on day 7 and from the vent on day 8. And by day 13, her echo had improved. And, she was able to, the anakinra was able to be weaned off, and she was able to be transitioned with oral steroids. So basically, she was treated with 5 days of remdesivir and CZP and antibiotics for 48 hours and discharged home on aspirin and prednisone. Diagnosis was MISC and myocarditis. So what is this? MISC, fever greater than 24 hours, lab evidence of inflammation and evidence of clinically severe illness requiring hospitalization with at least two organ involvements, and there should be no alternative plausible diagnosis, and may be positive for COVID by serology, PCR, or the antigen test, or having a history of COVID exposure within the 4 weeks prior to the onset. And here are some of the organ system involvement. The biggest thing is that these patients are the one that can present with shock, and so will tend to have abnormal cardiac markers, elevate abnormal coax studies, and as far as hematology, usually present with lymphopenia and neutrophilia. And as you can see there, the rash, they can present with rash similar to Kawasaki, and but it can be basically any manifestation as far as a rash. And so as far as, when these patients come in, we have a protocol for the emergency room. If the patient has unstable vitals, you want to, start your workup for your sepsis, going ahead and doing your COVID PCR, your IgG, as well as the inflammatory markers, as well as your other cardiac studies. So patient presented with fevers for 3 days, with fevers for 3 days, and 2 or more symptoms, as mentioned above. If the cause of the fever is not evident on initial evaluation, and the patient does not appear septic, these are the initial labs you want to do as well: CBC, blood culture, your inflammatory markers, your respiratory panel, your COVID PCR, your IgG, and based on if there are any abnormalities, then you can further discuss with the Pediatric Infectious Diseases Department on further management regarding admission. And just to mention real briefly here, this is the last case, a 10-year-old boy who had fevers intermittently for the last 16 days. When he presented, had a Tmax of 103, Tmax of 102 on the day of presentation. He had multiple family members who were ill and had COVID positive, but at the time he had knee swelling for the day prior to presentation and a history of a tick bite 1 month before. He had abdominal pain, vomiting, and diarrhea, but no respiratory symptoms. On his exam was febrile, noted to have mild swelling of the left knee, which was tender, but he had full range of motion. But based on his labs, the concern was based on his COVID exposure, 19 days later was whether this was MISC. So he had, a neutropenia and a lymphopenia as well with inflammatory markers. And troponin that was normal at the start, but an mildly elevated BNP. And some of his coags had been a little bit abnormal. His COVID PCR and IgG were positive. His echo was normal, and his inflammatory markers continued to worsen. And he was started on vancomycin, ceftriaxone, and doxycycline. Ultrasound only showed a small effusion, and the TAP showed 34,000 from the right knee, which didn't suggest septic arthritis. However, at 18 hours had GPC in chains, and later MRI showing osteomyelitis of the fever, and he was treated with ceftriaxone and discharged with ampicillin. He pretty much did well. So this child actually had Group A strep, Group A osteomyelitis, and not COVID MISC. So FUO is usually benign. Many times a cause is not found. FAPA is one of the most common of the periodic fevers. We want to always know which rash and fever combination are emergencies. Always consider Kawasaki in the differential of a fever and rash. And in these times, we need to know the presentation of MISC and, have a high suspicion and how to go about evaluating this condition. And the biggest thing as well is that before making a diagnosis of MISC, you need to rule out other illnesses. All right. So that brings me to the end. Any questions from anyone?
Anyone have any questions?
I actually do. So I have a young man that I just actually saw yesterday in clinic. And his mom, he came in with another fever, and then his mom, oh, by the way, said, well, he's had fever every month since February. And there's one documented visit in February at an urgent care with pharyngitis. And then yesterday, of course, he had a exudate on a tonsil, no ulcers or anything, a little bit of adenopathy. And then of note, mom said, and oh, by the way, his brother at the same age, his older brother had the same thing. And when I went back through his brother's chart, he'd actually had, I guess, a workup for sort of the PFAPA, rule out thing. Everything was normal, negative. He probably had fevers for about 9 or 10 months and is fine and doing great. And I guess my question is, I'm having mom do a log, but my question is I was presented with him, everything normal, growth, everything's fine. Am I obligated to do another workup, or can I just kind of go on the coattails of his older brother, as long as this kid continues to do fine, and maybe get one dose of steroids in him to see if it really knocks it down? But does blood work need to be done, given a family history like this?
I would say for sure you should at least do some initial blood work just to make sure you're not dealing with anything else. I mean, it sounds like it's highly suggestive of FAPA, but I would think, just go. I mean, these fevers you said are definitely recurrent, right?
Yeah, well, I mean, per mom, and so we're on a log count now, so she's got to keep a log, and then I want to bring him in every time for an exam as opposed to just, staying at home. I want to look in his throat and feel him.
Yeah, I mean, even though the history sounds, I would just still want to have a CBC, because as I said before, FAPA cyclic neutropenia can always look just the same as that too as well. The exception is that PFAPA, your growth is normal, but I think I would just want to make sure I have some basics, just like CBC and inflammatory markers, just to ensure. And then,
so do you do the whole cyclic neutropenia workup? You're coming in every 3 weeks because you may miss the neutropenia when they present with fever?
Well, I guess if monitoring him on the first set looks fine, I don't think we necessarily, and if he responds to one dose, I don't think necessarily every time he comes in, you have to go ahead and, do the cyclic neutropenia workup. But at least for a baseline, I would have a CBC at least done.
Okay, thanks.
Are there any other questions for Dr. Russell?
Maria, I had put something in the chat about using steroids in PFAPA and decreasing the length of the intervals, but Dr. Bellhorn said he thinks that usually goes away. What do you think about that, Marcia?
But the length of the intervals go away as far
Well,
as the steroids.
they shorten, you know, they shorten if you use the steroids, but he said he finds that usually it's usually just temporary.
Yeah, I mean, I've read before as well that, you know, using the steroids as well can actually increase the amount of occurrences as with FAPA. And so the thought is that, you know, if this child is going to be well, really, the steroid should only be used only, you know, if the child is really having symptoms or, you know, something that's going to make, say, for example, the child is having a function to go to, only when really necessary or the child is really uncomfortable. Because repeated uses of the steroids too, from what I've read, can actually cause more recurrences of these febrile episodes. So, Tom, you were saying that you think that these the use of steroids, is that going to like prolong the courses or decrease the courses? I'm not sure exactly what you were saying as far as. Tom, can you comment somewhere?
Sure. I don't know if you can hear me or.
Yeah, can.
Okay. I mean, that is, it's in the literature, and I have seen it in some patients, and some lucky ones, it doesn't affect the interval when you start the single dose prednisone. But I have had several, and I usually warn parents that this could happen, that instead of the every 3 to 4 weeks or something, and that it's usually pretty, you know, they know when it's going to happen. Sometimes, you know, it can be like in 10 days or something, they'll get the next one. And then, you know, but I talk it through. But it seems like several that has happened, it has in several months or 6 months, it will go back out to really the same time course when it was. So I always talk through the pros and cons of steroids. I definitely tell them not to use them if this looks like an atypical episode, or certainly any, you know, respiratory symptoms or other things like this. I'm usually comfortable with single dose prednisone because, you know, as you know, or everyone knows, a lot of this is just problems with the family if they're out of daycare and they're out of work and various things. And so, you know, it does help the child. But I've seen it in some of my patients that I follow initially, but many seem to go back out to their regular time interval. But again, it resolves in a certain period of time. And so I usually try to be optimistic and say it's actually one of the better diagnoses. We can manage it and it will eventually go away and there are no long-term sequelae.
All right, thanks.
Anything else? Well, that was a great discussion. Thank you so much, Dr. Russell, for your time and your information.
You're welcome. Thanks, Mary.
Thank you, everybody.
All right, bye.
Bye-bye.
Bye.